So Dr. Maria Isabela de Guia will present her results on the Rainer EMV.
Oh, sorry. Okay, good afternoon, everyone. I am Dr. De Guia from the Philippines, and I will be discussing the visual performance of the enhanced monofocal intraocular Ray 1 EMV lens after cataract surgery. So at the time of this research conduction and submission, I had no financial interests to disclose. However, at this current time, I am providing consultancy services to Rainer Intraocular Lenses Limited. I performed this research with my co-investigators, Dr. Caparas and Dr. Dionco, and the purpose of this study, done at the Medical City, Metro Manila, Philippines, was to evaluate the long-term visual outcomes after bilateral implantation of the enhanced monofocal IOL Ray 1 EMV. So for our study, we had 15 patients, total of 30 eyes, bilateral, who underwent phacoemulsification for cataract surgery, and they were implanted with the Ray 1 EMV. Patients were tested at 2 to 8 days, that was at T1, and 30 to 45 days from surgery. And what we measured was our monocular and binocular uncorrected and distance-corrected visual acuity at a distance of 4 meters, intermediate at 80 and 63 centimeters, and near vision at 40 centimeters. In addition, binocular defocus, contrast sensitivity, glares and halos, and light spectacle independence via a questionnaire were tested. So results showed that the mean spherical refraction was about minus 0.12 diopters and minus 0.15 diopters at T2, which is hardly significant. Our mean binocular UIVA at 80 and 63 centimeters and UNVA at T1 were minus 0.13, 0.37, 0.29, and 0.43 logmar respectively, while our mean binocular CDVA for T2 was at 0.17, that of our 80 centimeters was 0.39, 63 centimeters was 0.33, and our near at 40 centimeters was only 0.3. Okay. For our far and near mean monocular contrast sensitivity at T1, that was at 1.38 log CS and 1.42, and at T2 was at 1.36 and 1.33, while our mean binocular contrast sensitivity was at 1.55 and 1.56 respectively. We did notice though that 100% and 86% subjects experienced H1 halos and G1 glares at the first consult. However, these were at extremely low levels and were noted to be significantly less prominent at the second follow-up and significantly decreased with the dry eye treatment, which we saw. So during our first consult, we were actually surprised at how high it was, but within just 2 months later, we saw that it was already significantly lower. So implantation with enhanced monofocal Ray 1 EMV provided excellent post-op VA for distance, very good vision for near, which if you compare this actually to other studies that were done using this EMV lens with Caucasian eyes, it's actually quite significant. So only a fraction of our patients that we saw needed presbyopia correcting lenses post-surgery. And we still, even with excellent and very good near distance, had a very good intermediate. And these features, along with its outstanding contrast sensitivity, very low levels of glares and halo phenomena, yielded a high degree of patient satisfaction after surgery. So it has actually been my choice of lens since using it, and we are currently working on it, and even longer term studies of up to 1 year. And we hope to present those 1-year studies results for you for next year. Thank you for your attention.
Very nice, Abby. Any questions? Yes, sir. Yes, sir. Mm-hmm. Can you give the microphone to sir?
I've implanted around 250 lenses in the last year, and all of these patients, they require plus 1.5 diopter of spherical correction for near vision.
Oh, so we've been, may I ask your target for the target of your lens?
See, the distance was 0. They were
targeting for plano. So normally what we do is we do target for plano. However, we notice that the vision of the patients actually ends up maybe a little bit of a minus, plus 25. So when we target for plus 25, they come up to more plano. We find that maybe with our Asian eyes, it could present a difference. It was something that we were actually discussing earlier, that with most of our patients, only 25% of them have needed at this point presbyopia correcting lenses. Could be also contributed to dry eye treatment because we treat the dryness afterwards very vigorously after the treatment of, after giving post-op anti-inflammatory and anti-infective medications. So it could be something that we want to look into also in the future. Thank you.
The tricky part about all of this EDOF, Monofocal Plus, is actually refracting them well. If you have a good opto or yourself, you need to refract them well. So you know what, if you're achieving target, or you're a little bit plus or a little bit minus. So during the early times when people didn't do push plus, we used to do a technique called midpoint refraction, wherein you put in plus and you put minus, and then you report the midpoint. That way you kind of have an idea what your range of 2020 is. Maybe your 2020 between plus 0.5 and minus 0.5, therefore your midpoint refraction is 0. So it's very tricky to you perform better like this if you're a little bit biased towards the minus, right? It helps. That's why mini monovision is always an option. But when we evaluate, it's hard if you don't refract them, and over time sometimes they change refraction. So each doctor will have their own experience with a lens, but the results can vary because of that. But so far, I think there's no doubt that most of the EDOFs, they really the EDOFs are told are said EDOFs because they will be expected to be good at far and intermediate at the minimum, right? That's our goal of, and then we accept and we make the patients accept that they need reading glasses. I think that's on the safe side. We expect, and that's why they're labeled EDOF, or else they're labeled something else, like a full range of vision or something. So, but a target to target differences can affect. No? Any more? Yes, ma'am.
Refer this IOL for a driver by hobby or driver by job? Are they going to have glare and halos?
So far, based on our results, it doesn't look that it's quite significant.
These IOLs for drivers?
We have used this IOL for people who drive at night. Thank you.
Very good, Abby. Thank you.